So previously we had covered umbilical hernias and epigastric hernias in the section on ventral hernias, and today we will study about incisional hernias. So incisional hernia. So of all the hernias encountered, incisional hernias can be the most challenging and difficult to treat. Incisional hernias occur as a result of excessive tension and inadequate healing of a previous incision, which may be associated with surgical site infection. So why do incisional hernias occur? So incisional hernias occur as a result of, so they are a result of, number one, excessive tension, inadequate healing of previous incision, excessive tension, inadequate healing of previous incision. And the previous incision site may be associated with surgical site infection, SSI. So these hernias enlarge over time, leading to pain, bowel obstruction, incarceration, and strangulation. So these hernias can enlarge over time. And obesity, advanced age, malnutrition, ascites, pregnancy, and conditions that increase intra-abdominal pressures are factors that predispose to the development of an incisional hernias. So predisposing factors are So predisposing factors are those which increase intra-abdominal pressure. So what are those predisposing factors? So these predisposing factors are, number one is obesity. Number two is age, advanced age. Number three is malnutrition. Number four is ascites. Number five is pregnancy. So these are all the factors that increase the intra-abdominal pressure. Obesity can cause an incisional hernia to occur because of increased tension on the abdominal wall. What will obesity do? Obesity will increase the tension on abdominal wall and hence cause incisional hernia. And from the excessive bulk of thick pannus and large omental mass. So what happens in obesity? There is a thick pannus and large omental mass. Chronic pulmonary disease and diabetes mellitus have also been recognized as risk factors. So these are the predisposing factors, and chronic pulmonary disease and diabetes mellitus are also risk factors. So let us add these diseases: diabetes mellitus and chronic pulmonary disease. These are also predisposing factors or risk factors. Chronic pulmonary disease. So we have obesity, age, malnutrition, ascites, pregnancy, diabetes mellitus, and chronic pulmonary disease. Medications such as corticosteroids and chemotherapeutic agents and SSI can contribute to poor wound healing and increase the risk for development of an incisional hernia. So what are also implicated are medications such as corticosteroids and chemotherapeutic agents and SSI. So medications, predisposing factors are also medications such as corticosteroids. Medications such as corticosteroids and chemotherapeutic agents. So SSIs are also predisposing factors. Let us write down SSI also here, surgical site infection. So these are all the predisposing factors. So we have 9 predisposing factors: obesity, age, malnutrition, ascites, pregnancy, diabetes mellitus, chronic pulmonary disease, medications such as corticosteroids, chemotherapeutic agents, and surgical site infection. So large hernias can result in loss of abdominal domain, which occurs when the abdominal contents no longer reside in the abdominal cavity. So when there is a large hernia, it can result in loss of domain. So what is loss of domain? This is important in incisional hernias. So loss of domain is when abdominal contents no longer reside in abdominal cavity. Abdominal contents no longer reside in abdominal cavity. So what is loss of domain? Loss of domain is when abdominal contents no longer reside in abdominal cavity. So these large abdominal wall defects can also result from the inability to close the abdomen, primarily because of bowel edema, abdominal packing, peritonitis, and repeated laparotomy. So with loss of domain, natural rigidity of the abdominal wall becomes compromised and the abdominal musculature is often retracted. So what happens is loss of domain, natural rigidity of abdominal wall is compromised. Loss of domain में what happens is that natural rigidity of abdominal wall is compromised. That is number 1 point. Natural rigidity is compromised. Abdominal musculature is retracted. Abdominal musculature is retracted. So respiratory dysfunction can occur because these large ventral defects cause paradoxic respiratory abdominal motion. So when there are large ventral defects, respiratory dysfunction can also occur because in large defects, there is paradoxic respiratory abdominal motion. There is paradoxic respiratory abdominal motion. Due to which there is respiratory dysfunction. So in large defects, paradoxic respiratory abdominal motion occurs, which causes respiratory dysfunction. And then loss of abdominal domain can also result in bowel edema, stasis of the splanchnic venous system, urinary retention, and constipation. So what else does it cause? Loss of domain. Bowel, number 1 is bowel edema. Number 2, it can cause stasis of the splanchnic venous system. Bowel edema, stasis of splanchnic venous system. Then it can cause urinary retention and constipation. Urinary retention and constipation. So this loss of domain is one problem and multiple evils. So what is loss of domain? Abdominal contents no longer reside in abdominal cavity, and it causes natural rigidity of the abdominal wall to be compromised. Abdominal musculature is retracted. In large defects, there is a paradoxic respiratory abdominal motion, which causes respiratory dysfunction, and there is also bowel edema, stasis of splanchnic venous system, urinary retention, and constipation. So return of the displaced viscera to the abdominal cavity during repair may lead to increased abdominal pressure, abdominal compartment syndrome, and acute respiratory failure. So for loss of domain, when we return the bowel or return the displaced viscera to abdominal cavity, so return of displaced viscera into the cavity during repair will lead to increased abdominal pressure. Increased abdominal pressure. Increased abdominal pressure. Increased abdominal pressure. Abdominal compartment syndrome. So this is important. It can cause abdominal. So it can cause abdominal compartment syndrome. And acute respiratory failure, and it can also cause acute respiratory failure. So there is no simple mechanism for communicating the complexity of a ventral incisional hernia. Defect size, location on the abdominal wall, loss of domain, patient comorbidities, presence of contamination, necessity for an ostomy, acuity of the presentation, and history of prior repairs with or without a prosthetic allow an infinite number of permutations. The absence of a universal classification system has hindered comparisons within the literature and at meetings, indirectly delaying meaningful conversations about repair techniques and prosthetic choice. The tumor node and metastasis model for cancer staging is an enviable model to strive for in hernia repair. As such, a recent group sought to stratify ventral hernias into stages using a limited number of preoperative variables to accurately predict the two most meaningful surgical outcomes: surgical site occurrence and long-term hernia recurrence rates. So the two meaningful surgical outcomes that have been tried are surgical site occurrence and long-term hernia recurrence rates. So two of the most popular ventral hernia classification tools to date have been generated from expert opinion: the Ventral Hernia Working Group Grading Scale and the European Hernia Society System, EHS. The Ventral Hernia Working Group's grading scale uses patient comorbidities and wound class to predict SSO risk, surgical site occurrence risk. So about the Ventral Hernia Working Group grading scale uses patient comorbidities and wound class to predict SSO risk, and the European Hernia Society System assesses. So European Hernia System assesses hernia width and location. Using data from 333 ventral hernia repairs with no filter for technique, investigators presented a multivariate analysis. So using data from 333 ventral hernia repairs with no filter for technique, investigators presented a multivariate analysis that identified hernia width less than 10 cm, 10 to 20 cm, more than equal to 20 cm, and the presence of contamination as the two variables associated with wound morbidity, surgical site occurrence, and hernia recurrence. So this was used to calculate wound morbidity and hernia recurrence. Hernia location and patient comorbidities were not significant in this model for either outcome measure. Hernias could be grouped into stages 1 to 3 using width and wound class alone. So incisional hernia staging system was made and stages were 1, 2, 3. So low recurrence, low surgical site occurrence was there when less than 10 cm clean hernia was there. Moderate recurrence, moderate SSO, surgical site occurrence was there when less than 10 cm contaminated hernia was there, 10 to 20 cm clean was there. And stage 3 is high recurrence, high SSO, more than 10 cm equal to contaminated, or any hernia more than equal to 20 cm. So in order to assess this staging system, we need to know what surgical site occurrence is. So let us know what exactly surgical site occurrence is. So surgical site occurrence. So this was a term which was first introduced by the Ventral Hernia Working Group in 2010. Surgical site occurrence. So this term was introduced by Ventral Hernia Working Group. Ventral Hernia Working Group in 2010. So this group consisted of general surgeons and plastic surgeons who were interested in abdominal wall reconstruction, and they universally adopted the term surgical site occurrence. So I am reading this article from this hernia journal, and this journal provides the details of surgical site occurrence, and it tells the definition of surgical site occurrence. So definition of surgical site occurrence includes, so what is included in surgical site occurrence? So let us see what is included in surgical site occurrence. So surgical site occurrence includes wound cellulitis. Number one is wound cellulitis. Number two, non-healing incisional wound. Non-healing incisional wound. Number three, wound cellulitis, non-healing incisional wound, facial disruption. Number four is skin or soft tissue ischemia. Skin or soft tissue ischemia. Number five is skin or soft tissue necrosis. Skin or soft tissue necrosis. Number six is wound serous or purulent drainage. Wound serous or purulent drainage. Number seven is stitch abscess. Number eight is seroma, hematoma, and infected or exposed mesh in addition to SSI. Seroma, hematoma, infected or exposed mesh, wound dehiscence, and ECF. Wound dehiscence, intracutaneous fistula. So basically anything bad that can happen in a wound is included in surgical site occurrence. So this was introduced by Ventral Hernia Working Group and includes wound cellulitis, non-healing incisional wound, facial disruption, skin or soft tissue ischemia, skin or soft tissue necrosis, wound serous or purulent drainage, stitch abscess, seroma, hematoma, infected or exposed mesh, wound dehiscence, and intracutaneous fistula. So now we can understand the staging system. So incisional hernia staging system. Incisional hernia staging. Okay, let us see incisional hernia staging. So we have three stages. Stage 1. Stage 1 is low recurrence, low SSO risk. Low recurrence and low surgical site occurrence. So this is stage 1. And how will we say that this is a stage 1 hernia? If it is less than 10 centimeter and clean. So it is stage 1. Stage 2. Stage 2 is moderate recurrence and moderate surgical site occurrence. So this is stage 2 and it is less than 10 centimeter contaminated and or number 2, 10 to 20 centimeter 10 to 20 centimeter clean. So this will come under stage 2. Stage 3 will be high recurrence, high SSO. Stage 3 is high recurrence and high surgical site occurrence. So how will we say that this is a stage 3? If it is more than equal to 10 centimeter and contaminated. Number 1. Number 2 is any more than equal to 20 centimeter. 20 centimeter. So this will be stage 3. So this is the incisional hernia staging. So in this system, hernia location and patient comorbidities were not significant. Hernia location and patient comorbidities were not significant in this system, in this model. So hernias could be grouped into stages 1 to 3 using width and wound class alone, with ordinal increments in both outcome measures. Stage 1 hernias are smaller than 10 cm and clean, associated with low SSO, as we have already seen, and recurrence risk. Stage 2 are 10 to 20 cm clean or smaller than 10 cm contaminated and carry an intermediate risk of SSO and recurrence. Stage 3 hernias are either 10 cm and larger, contaminated, or any hernia 20 cm larger, and these are associated with high surgical site occurrence and recurrence risk. So table 45.3 demonstrates reported rates for SSO and recurrence using the system. So this is given. Table 45.3. Surgical site occurrence and recurrence rates. So in stage 1, there was 10% surgical site occurrence rate and 10% recurrence rate. Stage 2, 20% and 15% recurrence rate. So out of 151 patients, 30 had an SSO and 22 had recurrence rate. Stage 3, 42% SSO rate and 26% recurrence rate. So this staging system is simple but comprehensive in its ability to stratify patients by risk of wound morbidity and recurrence, the two chief outcome parameters of repair. So importantly, the system does not include intraoperative details such as approach, open versus laparoscopic, mesh choice, biologic versus synthetic, or mesh position, onlay versus sublay. It is hoped that this platform can be the basis of future inclusion and exclusion criteria for studies regarding technique. So now treatment, operative repair. So how do we treat incisional hernias? Treatment of incisional hernias. So primary repair of incisional hernias can be done when the defect is small, less than equal to 2 to 3 cm in diameter. So primary repair of incisional hernias can be done when the defect is small, less than equal to 2 to 3 cm in diameter, and there is a viable surrounding tissue, or in cases in which the hernia was clearly a result of technical error at the initial operation, such as a suture fracturing. So it is done when defect is small, less than 2 to 3 cm in diameter, and there is a viable surrounding tissue, or in cases in which the hernia was clearly a result of technical error at the initial operation, such as suture fracturing. Larger defects more than 2 to 3 cm in diameter, defects more than 2 to 3 cm in diameter have a high recurrence rate if closed primarily and are repaired with a prosthesis. In general, recurrence rates seem to increase with time. This suggests that incisional hernia is likely a chronic disease, and an array of management options will need to be utilized to care for a patient throughout the course of their life. Prosthetic material may be placed as an onlay patch or to buttress a tissue repair, interposed between the facial defect, sandwiched between tissue planes, or put in a sublay position. Depending on its location, several important properties of the mesh must be considered. So let us write down treatment of incisional hernias. So incisional hernias. So when the defect is small, so according to defect size, small defect, that is less than equal to 2 to 3 cm in diameter. If the defect is less than equal to 2 to 3 cm in diameter, or number 2, technical error at initial operation. Technical error in initial operation. Example, suture fracturing. So in these cases, what do we do? Primary repair of incisional hernias. You know, is a primary repair. So if a small defect is there less than 2 to 3 centimeter in diameter, technical error in initial operation, example suture fracturing, we do a primary repair. And if the defect is large, so if we have a large defect, that is more than 2 to 3 centimeter in diameter, more than 2 to 3 centimeter in diameter. So what we do in such cases is repair with prosthesis. Repair with prosthesis. So we place a mesh which can be in any position. In general, recurrence rates seem to increase with time. So in general, recurrence rates seem to increase with time. So we can take incisional hernias as a chronic disease. So let us revise. As we have completed incisional hernia from this Harvesting textbook, let us revise. So incisional hernia, what we have learned is that it is a result of excessive tension, inadequate healing of previous incision, and surgical site infection. So predisposing factors are those which increase the intra-abdominal pressure, such as obesity. Obesity, what does it do? It increases the tension on abdominal wall. Then we have age. Increasing age will cause more chances of it is a predisposing factors for incisional hernia. Malnutrition is a predisposing factor. Ascites, pregnancy, diabetes mellitus, chronic pulmonary disease, medications such as corticosteroids, chemotherapeutic agents, surgical site infections. Then loss of domain is an important term in incisional hernias. What is loss of domain? Loss of domain is when abdominal contents no longer reside in the abdominal cavity. So what happens when there is a loss of domain? When there is a loss of domain, natural rigidity of the abdominal wall is compromised, abdominal musculature is retracted, and in larger defects what happens is a paradoxic respiratory abdominal motion tends to occur, which causes respiratory dysfunction, breathing difficulty, and other things that are caused by loss of domain is bowel edema, stasis of splanchnic venous system, urinary retention, and constipation. So even if we return the displaced viscera into the abdominal cavity during a repair, it can cause increased abdominal pressure, and increased abdominal pressure can result in abdominal compartment syndrome as well as acute respiratory failure. Now there is a new term called surgical site occurrence, which was introduced by Ventral Hernia Working Group in 2010. Ventral Hernia Group was people who were interested in abdominal wall reconstruction, such as general surgeons and laparoscopic surgeons and plastic surgeons. So this term surgical site occurrence, it encompasses several entities such as wound cellulitis, non-healing incisional wound, fissure disruption, skin or soft tissue ischemia, skin or soft tissue necrosis, wound serous or purulent drainage, stitch abscess, seroma, hematoma, infected or exposed mesh, wound dehiscence, enterocutaneous fistula. Using this term surgical site occurrence and low recurrence, we have the incisional hernia staging system. So stage 1 is low recurrence and low SSO. So stage 1 hernia, incisional hernia, is less than 10 cm in width and clean. 2 parameters. Stage 2, moderate recurrence and moderate SSO. It can be classified by width, that is less than 10 cm contaminated hernia if it is, or 10 to 20 cm clean hernia. Stage 3 is high recurrence, high SSO, which is more than equal to 10 cm contaminated or any more than equal to 20 cm. Treatment for incisional hernias is small defects and large defects. Small defects less than equal to 2 to 3 cm in diameter can be closed by primary repair. Or if there was a technical error in the initial operation, example suture fracturing was there, it can also be repaired, primarily repaired. And if there is a large defect more than 2 to 3 cm in diameter, then repair with prosthesis has to be done. In general, recurrence rates seem to increase with time. So we have completed incisional hernias. So in the next section, we will study about the prosthetic materials for ventral hernia repair, and it will include permanent synthetic mesh and biological materials, absorbable synthetic mesh. So basically we'll study about meshes and then we'll see the operative techniques in ventral hernia repair.